Good morning, everyone. This is I think now our third virtual forum, and we want to walk through a number of different topics with you today. We're actually going to spend a little bit of time presenting on some topics. We still want to make sure that we are getting and responding to the questions that you've submitted ahead of time, what you submit during this forum. So we're still going to reserve time, plenty of time to walk through questions, but there are a couple topics that we want to walk through today. But first, as always, I want to start with, again, a huge thank you to all of you. Right now, we have team members that are out in the snow screening, and that's not their typical job. There's just been so much accommodation to this really challenging environment by all of you. The management team, the shareholders, the physicians, we just can't thank you enough for how patient you have been, for how accommodating, how adaptable you've been. I think in our future environment, as we come to the new normal, being adaptable is going to be so critical for every single one of us, and you've demonstrated that already. The other thing I really want to thank you for is your engagement. The amount of emails and thank yous and questions and inquiries that we have gotten because of these forums, because of the information that we've sent out has been outstanding. Please keep that coming. Please stay engaged. That's how we're all going to get through this together. But as I said, we want to walk through a few different topics. We've made some big advancements and a huge investment in telehealth. And the early signs are that has been very, very successful, both in the number of patients that we've been able to take care of, the response from a marketing strategy that we've put together or advertising that we've put together, and the experience scores have been outstanding. So we want to walk through a little bit with that with you. And so we actually have our Chief Medical Information Officer, Scott Reynolds. He's going to be joining us. He's going to walk through a lot of that, and then we also, because we're doing this disinfecting of the N95 masks, we volunteered for that. We have 25 providers around the community. We have gotten a lot of questions around how that works and what that looks like. And so later on, Walt is actually going to do a tour. He's going to guide us through a tour of how that process works, where we're doing it, and what it looks like. We still have John Bring and Peg on the broadcast here to answer questions as they come in. But first, I just want to quickly outline really where we are with the current status of utilization within the Omaha Metro. And actually, I'm going to come back to that because I got to figure out how to bring that up in my screen share, but give me a quick second here. I'm going to bring that up in a minute. I'm actually going to, sorry, forgive me. I'm going to jump ahead to where we are with telehealth, and so I'm going to bring in Dr. Reynolds. So Dr. Reynolds, welcome to the stream, and welcome to the virtual forum. If I can get him up here. We are having some technical difficulties here. is pause right now. I'm gonna.
I think it might be the screen share. We might have to get rid of the screen share.
Dr. Reynolds?
Yeah, I can hear you.
You're on. Can you hear me?
I can hear you. You're a little choppy, but
all right. I'm gonna have you take it away. I'm gonna move to the telehealth slide.
all right. Hey,
I'm gonna move to the telehealth slides, and then I'm gonna have you walk through. We might have to fix our machine here a little bit.
all right. Hopefully everybody can hear me. Levi's definitely a little choppy from my end. But hey, first of all, I appreciate the chance to talk with everyone today. And I appreciate the team kind of inviting me to talk about telehealth. Before I do that, though, I personally also wanted just to say thank you to everyone who's listening and to all our staff and to the administration. I know Ryan and Charlie mentioned this last week and said thank you, but I personally want to say thanks. I know the last several weeks have been kind of scary and frustrating and just up in the air. And I appreciate everybody's maintaining good attitudes and going with the flow and being flexible both in the clinic and the hospital. So I know it's been kind of crazy, but I definitely appreciate that. Administration's been working like crazy behind the scenes, trying to keep everybody employed, keep things working. So I just, all the doctors want to thank everybody for what they're doing. As far as telehealth, so I know Levi mentioned telehealth. He asked me to come in and just chat about it for a little bit. Just to give you a quick background, our group, the clinic's also, or has actually been thinking about telehealth for several years. It's always come up in meetings off and on about wanting to do that. There's been some doctors who have wanted to utilize that for patients who live a long ways away and for maybe some post-op visits and just from a patient satisfaction standpoint, so they wouldn't have to, take a half a day off of work to come in for a 10-minute visit. There's been limitations in that. And but it has been sort of in our radar. And so we've actually had a group, even going into this past year, it's been an initiative that we were going to look at anyway before all this started happening. And so they started looking at some different programs and some different apps and just kind of what that process would look like. And so that had already been going, fortunately for us, kind of behind the scenes here over the last, really several months. And then obviously when the COVID-19 outbreak happened, obviously it just jumped to the top of the priorities as far as getting going. Levi had put Chris Denny sort of in charge of this initiative probably about 5 or 6 weeks ago, right when this all started, and just got this ball rolling. There's been a lot of people involved. Everybody's been working really hard on it. I wanted to give a shout out to Eric Smoyer early on. He kind of jumped on and was helping kind of sort through what apps we could get up and going really quickly. Ultimately, we decided on using an app called Zoom, which most of you probably have heard of by now or even used. And it was one of those things where we had to have an app that was easy to use, pretty wide known. And then obviously just from a cost standpoint, I mean, some of these apps can be hundreds of thousands of dollars a year. And so we didn't want to, jump into any long-term contract or anything major. So Zoom let us just kind of do a monthly fee, and it was pretty reasonable. And we just paid by provider. And they do have a healthcare version that was encrypted and had a little bit more security to it. And so just to turn it on overnight, we decided to do that. And early on, then 5 or 6 weeks ago, Eric and Chris and I had several meetings, just kind of walking through what this potentially could look like from a patient standpoint, from our standpoint, and then getting access involved and coding and billing and all this other stuff, trying to figure out how this would all work. Essentially what we did, we started simple and we just had some follow-up visits. I basically called 3 or 4 patients since we'd never done it and just said, hey, would you be willing to try this? We're kind of working through it. And they were willing to be guinea pigs. So we did some easy kind of post-op visits for that. And then worked into some follow-ups, and then gradually worked into, somebody who needed an MRI follow-up. We would get them on, and you could pull up the screen and walk through the MRI with them and scroll through it and show pictures and basically show everything you were looking at on the screen. and then eventually worked our way up to new patients. And new patients are way more complex because you got to get their demographics, you have to have a way to get their insurance information and health information, all that stuff ahead of time, just because obviously they aren't going to be in the clinic. And so just kind of working through that process and everything, we did that. I started seeing some patients quickly. We had a group of physicians, probably 4 or 5 other docs, who got involved and were kind of throwing out some comments and input ideas. And then they started seeing patients, and then little by little, we kind of opened up basically access to all the doctors over the last several weeks. We've brought in rheumatology, we've brought in physical therapy, and have just been working through the process. All the docs currently, right now, are using it a little bit differently. Some docs have still been seeing patients and then just kind of adding on telehealth visits randomly here and there. I initially started seeing some telehealth randomly and then kind of adding them on at the end of clinic. And recently, over the last week or two, I've actually just been seeing everybody from home. And so my nurse is at home and I'm at my house, and I see all the patients, and then we have ways of communicating back and forth to get all the information as far as the patients getting their work notes and their therapy notes and prescriptions and things like that, and getting their follow-up set up. And so, you know, everybody's a little different on how they do it, but that's the process we've kind of worked through recently. You know, we've worked through all the insurance issues as far as payment, and all those codes have gone through and things have looked good. I think we're showing you here the some of these graphs. The first time I've seen them here too, but you can kind of see how just over the last several weeks we've increased volume. The clinic volume is always kind of a hybrid. You know, we're still seeing some people in clinic, but also mixing in some of the telehealth visits, just trying to keep exposure down and keep people out of the clinic if they don't have to be there. Rheumatology started seeing people. You know, physical therapies even started seeing some patients, and kind of, I guess, having continued monitoring of patients from home and checking in, things like that. You know, from my standpoint, I guess I'm not sure what everybody's interested in. For the most part, this has worked fairly well. I mean, you can see here that patient experience scores have been fairly high. It's definitely not perfect. I mean, there are some things as far as, you know, seeing patients and not being able to do an injection immediately, or not being able to get an x-ray immediately. You'd be surprised at how much you can accomplish just by talking with somebody and doing kind of a self-exam on themselves, really, and walking through that. But the way we've kind of done it is, if somebody needs an injection and I'm seeing them on a Thursday, for example, I just have some time set up on Monday morning where they just sneak in real quick, get the injection, and leave. They don't have to spend a lot of time. We don't have to interact or chat too much. And again, it just limits exposure. Or I've had people come in, just sneak in, get an x-ray, and then take off, and then I follow up afterwards. So it has worked out pretty well. And I do think long-term, you know, obviously that we just got this thing up and going very quickly. It's not absolutely perfect, but I do think this is probably going to stay. I mean, it's kind of been nice from a silver lining standpoint. It's, again, been something we've wanted to do for a long, long time. And this has just kind of forced the issue. So long term, I'm sure we'll kind of relook at it and decide what program we'll want to go with in the distant future, I guess. I doubt Zoom would be the long-term plan, but we'll have to work through that. Some of it will depend on, you know, after this is all said and done, what kind of visits insurance actually lets us bill for. But it'll be a nice thing that we can continue to utilize in the long term. And we've learned a lot. It's kind of been nice because it's just forced us over the last several weeks to basically hammer this out and work through it and kind of find out the pain points and some of the issues as far as patients getting logged into and making it work. And it'll be nice to kind of utilize that information as we look at different options, I guess, going into the future. So, Levi, I don't know if there's anything else specifically you wanted me to mention. You know, that was just kind of a little bit of a history and kind of rundown where we're at now. I don't know if you have any thoughts or anything you want me to expand on, or any questions coming through. I can't see any, but
Yeah, I think there's one question here. By the way, that was outstanding. Thank you. That was very ad hoc. We had some technical difficulties, so forgive me, Dr. Reynolds. Yeah, there's one question here that maybe you could address. Will telehealth visits continue once the pandemic subsides? I think the quick answer is absolutely. This is a key part of our strategy. We've mentioned this a couple times through these virtual forums. In other words, if we want to be OrthoNebraska and take care of patients across the state, telehealth is going to be a key part of that strategy. I think What remains to be seen is exactly how the insurers will govern this, how they will compensate us, reimburse us for this. I think there's still some questions, but by far and away, this is an important part of our strategy over the long run. So I don't know if you have anything to add to that.
Yeah, no, I completely agree. I think, like I said, we've been talking about this actually for the last couple of years. And, for example, we have patients from Harlan, Iowa, and I feel terrible they have to drive, an hour and a half here just for a quick post-op visit or just for a quick check-in. And I've always felt like it'd be awesome if we could just have a way of doing this. Some of it has been limited due to just insurance issues and being able to get it covered. But we have patients from, like you said, outstate Nebraska who have called in and want to get surgery set up, but you've never even met them. Just a few months ago, I had somebody who came from like 4 hours away, had surgery technically set up the next day, and they came in and just saw us the day before. And that would have been a perfect situation. They had already sent the MRI in, I'd already seen it. And we could go over all that, have a game plan, have it all ready to go. And then, they come in here, and then for follow-ups, they don't have to drive 4 hours back, and we can do their follow-ups through telehealth. So I definitely think this is something that's going to continue. It's been nice, like I said, because it forced the issue. It'll just kind of be deciding, what program we want to use going forward, what's cost efficient, how doctors envision themselves kind of using this long term. So it'll be exciting. I think nationwide it's going to be that way, but we'll definitely keep on it here locally too. So,
and then Dr. Reynolds, are patients being charged the regular office visit fee, or do insurance companies consider these sessions as office visits? We agree, by the way, that this is a great service. As I said, this is a key part of our future, especially in a rural environment. Obviously, there's a lot of accommodations right now by both CMS for Medicare, Medicaid, as well as the insurers on how reimbursement and fee structures are working. There are plenty of accommodations. However, just the history of this has been something that I think both the insurers and the providers have been working on, trying to create a new set of rules. So I think it's difficult to predict exactly how it'll work in the future on the other side of this pandemic, but I'm confident that because of the trends that were happening well before it, that there will be a fee structure and reimbursement that'll make it worthwhile for us to do. So I don't know.
Yeah, I agree. I think, right now they are, I guess, paying equal to kind of what normal visits would be, although there are some limitations on, the way you can bill for somebody's pretty complex. On you have to have a certain amount of an exam and certain complexity with the visit and certain tests and different things. So it is kind of complex to explain, but I do think in general right now they are billing fairly equivalently. Long term, they'll be, I guess, kind of up in the air. The one thing I wanted to mention, I guess, the one thing we're doing, if somebody is seen, like, for example, on a Thursday and we do a telehealth visit and we decide they need an injection, for example, normally we would have just done it right then and they would have taken off. Well, in this case, what I'm doing, and I think what most of us are doing, is just having them come back in, for example, on a Monday morning real quick, getting the injection and taking off. They're not getting double billed for a clinic visit. They're just getting billed for their injection. So we're kind of grouping that all in as one continued visit. It takes a little bit of organization on the backside to make sure all that's done, but they aren't getting double billed for visits and things like that. So we're trying to kind of keep that similar to what it was before.
Great. All right, Dr. Reynolds, thanks for jumping in. I'm gonna keep you on here. But we're gonna transition topics. I wanted to go back really to where I wanted to start, which is, how is Nebraska, how is Omaha doing with the management of COVID right now? So we're going to add in a quick slide. And what you can see here in Nebraska so far, it's roughly, I think this is as of April 16th, so relatively recent. We've tested about 12, maybe probably closer to 13 now, 1,000 people. About 1,000 of them have tested positive. There's been more than 20. I think there was actually a couple more reported last night, deaths, unfortunately. But it's also really important. We brought out some of these metrics last week, and I want to make sure that everybody is aware of how Omaha is doing and how much resource capacity there is in the community. Right now, as of the 16th, there is about 590 beds that are available. So we're actually at a 55% occupancy rate. A lot of the things that we have been doing and contributing within the community of reducing down elective surgeries really creates a lot of capacity within the healthcare community right now. There are 43 that have been diagnosed with COVID that are inpatient right now, 51 that are under investigation at 12 different facilities, and then roughly 100 vents out of the approximately 400 ventilators that are available are in use, and 21 of those are for confirmed COVID patients. So the unfortunate part of that's actually up about 8 patients from last week. And so those are key things that we have to monitor really to start to understand what President Trump outlined last night, which is how do we start to resume our normal course of business. And so while we don't have all of the answers, and a lot of what was outlined by President Trump last night is going to be directed at the state level, we have to wait for direction from Governor Ricketts. But monitoring these types of statistics are going to be important to understanding what our resumption period and our resumption approach looks like. If you recall, for the state level, Governor Ricketts has a slightly modified plan to other states. He has been issuing what are called directed health measures by county. The counties of Douglas County really started in early March, and he extended a period of directed health measures through the end of April. And in that directed health measure is the restriction on elective cases. He is evaluating how long that period of that restriction on elective cases will be. We were fortunate to be on a call with Governor Ricketts and the other NHA CEOs yesterday, and actually Dave Zuhab participated in that, and he started to outline some of his thoughts, and he wants to make sure that, one, we have plenty of PPE. Each health system, each hospital has sufficient PPE in order to resume in case there is a spread or an outbreak by community. And he also wants to make sure that we have sufficient capacity. Just for illustration, how much inpatient and ICU capacity needs to be retained if elective procedures are resumed. He wants to maybe create a baseline for that. My point in outlining this is to connect the idea that obviously President Trump has outlined his resumption plan. He's expecting that the state adopts plans that are appropriate and applicable to their environment, their cities. And then these statistics in our county and in our community, based off of how Governor Ricketts has applied his directives at the community level, all of these things start to tie together. We have a team that is working on the safety measures. Obviously, we want to resume in an incredibly safe manner. We want to protect all of you. We want to protect our patients. We want to make sure that this barrier that we've set with our screening of patients even entering onto campus keeps everyone safe. All of that's going to need to work together, but there is a group that's starting to analyze this on how we're going to resume. And so I'm just going to pull in Peg and John. Maybe there might be a couple questions tied to this, and I want to get their thoughts as it relates to some of the work that we're doing right now to consider resumption. So I might turn it over to John. Any thoughts on what I've outlined so far?
Yeah, I think the top priority is maintaining our our safety that we've put in place already. We are not looking, if they say we can start to ramp up a little bit, that all this goes away. We are taking a lot of time to look at our current workflow, where we're screening people, current risk factors, all those things, all the places that there could be associated risk, and take a really cautious approach to not necessarily peeling things back, but how do we integrate some of this into our what we may consider our new norm. So taking some time to definitely work with the infectious disease team, and also staying up to date on current practice. And so again, it's not necessarily going to be, we're just going to all of a sudden abandon all these things. We are going to take a very cautious approach to maintaining that level of safety that we've put in place up to this point.
Yes, thanks, John. I'd like to add too that as we grow, evolve through this pandemic, and even after we start doing more procedures, we will continue to wear masks. We'll continue to protect ourselves and our patients until we get a vaccine and active testing available. So I noticed there's a couple questions about testing. And in the last couple weeks, the amount of testing has increased tremendously. So yes, anyone now who has signs and symptoms or was potentially exposed and is concerned is able to be tested. We're seeing more people coming through our ED as PUIs, people under investigation, wanting to be tested, and it is available. Now, the other thing I'd like to add to that is that because the testing is starting to be more available, we've actually had in the state of Nebraska, the National Guard is out there doing prevalence studies. And what that means is they have set up tents and are evaluating people in hot spots like Grand Island and Hastings and Kimball, and now they're moving up to South Sioux City to do a prevalence study to see how common is our positive rate right now. So we've got enough testing available now that we can start doing prevalence, which is going to help us tremendously to start to move up to ramp up again to our normal work.
Peg, can you just address the key part of, I think, this great question here that came in is, just help us understand a little bit around testing for high-risk individuals, healthcare staff, and then the general public. Maybe just be a little bit more precise with availability and turnaround time with tests for anyone. Yeah.
Sure. There's a variety of different tests now available. The one we started with was a PCR test that, as you know, would take 24 hours at least to run the test, and then a day or two to get results, and depending upon where it was sent. Well, now the Med Center as well as CHI and other facilities are now getting testing equipment and reagents available to them. And so we typically can now, with the available testing, get results within 24 hours. And typically if we test before 10 a.m., by the end of the day, we're starting to get results in our ED. So it's getting more prevalent. The other thing that is going to help us a lot is they're developing antigen antibody tests. I'm sure you've heard something about that on the news, but it's a point of care testing where it's about a 45-minute turnaround. And right now we have a few kits in the state that they're working with, and those are available in some of the hot spots right now, like in Grand Island, so they can quickly identify people. They're not perfect. They're more of a screening test because there is some issues yet with false negatives, but it's better than what we've had in the past. So if you are concerned or you have a family member who is concerned and wants to be tested, I'd contact your primary and or touch base with some of the staff here at the hospital, and we can help you figure out where's the best way to get tested.
The other consideration for resuming elective procedures obviously is how we're doing with PPE. As I mentioned, the governor wants to make sure that hospitals, providers have sufficient capacity for PPE for their staff, and how we take care of patients. And so I want to do two different things real quick. I want to outline, we get a lot of questions around how much capacity we do have for PPE. This gives you a general sense, and this is based off of current patient volumes and our burn rate of supplies. So we have pretty good inventory for key supplies, or N95 masks, or procedural masks, gloves, gowns, hand sanitizer, our disinfecting solution, all that we have. Again, at the current burn rate, we have more than 4 months of supply. There are a couple areas where we have more challenges. Like everybody, it seems like we have limited supply of toilet paper, and things that we want to make sure that we're building inventory is disinfecting wipes and hand soap. But we wanted to make sure that you had a good understanding of where we sit with PPE. Brooke and Doug and the team have done a great job of both looking for and quantifying PPE, and I would say that Lori and Peg, in a lot of foresight, we have done a great job of making sure that we had a stockpile should an event, maybe not quite like this because it's difficult to predict an event to this degree, but we had a good cache of a lot of this type of PPE in advance. So a lot of foresight and a lot of hard work has gone into this. And then additionally, for N95 masks, I think hopefully you got a chance to see the article in the newspaper about how we are now participating with disinfecting the N95 masks for providers around the community. So now I'm going to bring in Walt, and Walt is he's going to do a tour and describe our processes around the disinfecting process. So Walt, are you there?
I'll be back. Hello, everyone. Great transition into utilizing the PPE and being able to keep our utilization down. We have now partnered with Nebraska Med and the coalition to provide a service to the community to re-sterilize N95 masks. So kind of going to walk you through the process. My name is Walt Nichols, Manager of Surgical Services, by the way, for those that don't know me. And for those that haven't been to the west side of WARS, we're going to do a quick little tour of how we utilize those and stood those up quickly to be able to provide this service. We have about 25 clients signed up right now with us, varying from rehab centers, smaller hospitals, Omaha Fire Department, Omaha Police Department, that we're going to start reprocessing these masks for. We've done a few clients this week, really going to ramp up next week. So we've already ran a cycle this morning, but we'll kind of run through the process with you. After they signed up with us and set up a time for delivery, they're going to come to the back dock by ED, if people know where that's at. And they're going to bring their mask into us individually in brown paper bags, labeled, and in totes. And we have a cart here that we'll place those totes in. Once they bring us the totes, they're going to come in and, of course, wash their hands, right? Always washing hands through the doors, and then come back and sign in. They're giving us their information so that we can get that totes and then identifies quickly back to them. So we'll kind of walk you through to the UV room. Now we're just finishing up a cycle here. You can see the masks in our UV room. We have capacity now to do about 60 masks at a time. The setup, really just a quick overview of the setup. This is our robot. We have one robot that we set up to irradiate the mask. Then it takes about 15-20 minutes for the cycle. Shut the cycle up. Then we bring it to the other side of the room and again shoot the mask so that we're getting both sides of it. Again, the whole process, checking in and bringing them back, takes about an hour. And we have a little sensor on the floor there that tells us how many millijoules are actually getting to the mask. And then we're going to back up just a little bit. And I'll show you the sensor here. This is our machine. We're outside watching. That bottom number, that 300 millijoules, is what we're looking for that range to get up to as we monitor those. And then we come down. Obviously, we're bringing in, checking them in through the dirty side. And you can see Corey and Jay right now are checking them back through the clean side. Once the process is complete, then we will return them into their own bags, stapled, with their name on it, and then a brown paper bag for when to return the dirty back to us. We take these totes, place them on the back clean cart for when people come drop off their dirties, then they're coming back and pick up their cleans. Should be a 24-hour turnaround for most cases. That's it. Real simple process. Levi, do you have any questions?
And we didn't have a lot that came in, but Walt, I wanted to thank you. I'm gonna bring in both John and Peg here, just to add any context. But I think one thing that we need to acknowledge is, this robot, this process was developed by the Med Center, both UNMC and Nebraska Medicine, and they donated the robot. They also are helping us cover all the costs. So I think this is a great service that we're providing, that the staff has become very competent in very quickly, and that we're helping the community. But we also need to make sure that we acknowledge the help that we got from Nebraska Medicine in this process as well. I don't know, Peg, you've been heavily involved. This is something near and dear to your heart. Anything to add?
Well, I just think it's so exciting that we're able to participate in this and help the community. There are actually, the Med Center actually bought 6 of these with their biocontainment grant money, and each of the different coalitions in Nebraska has one. So there's one in O'Neill, one in Lincoln, and then out west as well. So the Med Center actually did all the research on this, published it, and now it's being used all over the United States. So we're able to, each of the masks can go through 3 to 5 different cycles before it starts to break down. So it really expanded our use of N95s. It's exciting. It really helps everyone out.
Peg, can you answer this question? Do we do tests on the masks after we process them?
Okay, good question. What we did was the Med Center, when they developed their program, they did all the validations on the testing based upon the millijoules that are actually hitting the mask, how far the robot is from the mask, and so forth. And so all of that studying was done ahead of time. And as long as we follow their same process and their same criteria, we do not need to do any validation tests. It's very similar to a laboratory test when the manufacturer does all the QI and validation. And so that when we get it in the lab, we don't need to do any validation as long as we follow the manufacturer's instructions. So at this point, no, we are very confident and comfortable that we are killing the bugs.
Yeah, Walt, do you want to address our staff safety with this question? How are we making sure that everyone is safe using gloves? How are we handling them? Just want to talk through that.
Sure. Same thing. We mirrored the Nebraska Med model. These are contact precautions. So as they're coming in dirty to us, it is full protection, gowns, gloves, eye protection. Then of course, after the UV sterilization is done, then it's down to also contact precautions. So they're wearing the proper, it's down to just gloves at that time. I think to kind of put a little technical behind Peg's answer there, the testing down at the Med Center proved that it kills anywhere from 2 to 5 millijoules. And if you saw earlier on the sensor, we're hitting these with 300 millijoules. So it is, tenfold that we're getting the dosage correct.
Thanks, Walt.
So cool, so cool.
All right, well, we'll let you go. We'll let you get back to your regular job, and thank you for jumping in and doing this for the community. Great work.
You bet. Thank you.
Actually, that brings me to one other topic I want to cover, and that is the nature of how much our day-to-day roles have shifted over the past month. We started this conversation around telehealth in the future. We obviously want to get back to our day-to-day work of taking great care of orthopedic patients, but I just want to acknowledge how many people have stepped up and have taken on different roles. We actually have a neat slide here talking about how that has shifted, and I'm going to pull it up here real quick. We have right now we have 196 people that are working from home, roughly 30% of our staff all doing their part to make sure that we're not spreading this virus. Right now we have about 35 to 40 shifts per day that are available in the labor pool, taking on those screening responsibilities, the virtual waiting room, our sterilization team working on these masks. We also have a whole host of staff members from the inpatient unit and pre and post cross-training in the emergency department. And now I think it's really important that we take a step back and really try to understand how our processes can be enhanced while we have the time, while we don't have our typical 30, 40, 50 surgeries a day or almost 400 patients coming through the clinic. How can we take a look at our processes, understand what's working, understand the enhancements that maybe we can make in a short period of time, and put those in place as we start working on our resumption. And so we're gonna work with project managers. We're gonna work with assistant managers and managers to put in some projects over the next 4 weeks to take a look at those processes and see if we can find some improvements. So I just want to highlight this as, while obviously our volumes are very different and we're responding in a different way, we are going to resume our core business, and now is the time to take a hard look at things that we can enhance. With that, I might just bring in John here. John, anything to add or anything to focus on as it relates to both how people have taken on different roles and the things that we're going to look at over the next few weeks?
We started to dive into all this is how do we become more prepared and flexible to adapt to ever-changing situations, and that became very clear early on. So one of our top strategies was figuring out a way to
Sorry, John.
Oh, you're good. One of our top strategies was how do we better support multiple areas with the staff we have available. So that's where the cross training became very important, and we identified that the ED would also be a likely place that we could see a surge. So it's also given us a great opportunity to build new relationships and learn new workflows and get to know new people. So I think those who have cross trained and the ED staff have really enjoyed that experience as well. We're continuing to dive into other projects like Levi said, something that while we have some time, let's focus on those and try to get those knocked out here in short sprints. And so if there's ideas on how we can do things better as we move forward, people have ideas, definitely bring those forward to us and we can try to incorporate that into the work we're already doing now.
Thanks, John. Okay, so there's a host of different questions, so I'm going to just try and tackle those. One of the questions that Jennifer is asking is, I think this is related to our PPE, and yeah, we did state that the 4 months is based off of current volumes, and that obviously is a dip in our volumes. What's really important to us is that we continue to replenish our supplies, and as of right now, we work with Owens & Minor and our supply chain team. Doug is trying to understand exactly how we are getting allocated our supplies, and we're making sure that we're pulling based off of our allocation. And so far, we have not seen a slowdown in the allocation of supplies that we traditionally request. So on a weekly basis or a monthly basis, we need X amount of gloves and gowns in order to take care of our traditional volumes of surgeries. We get that amount of supply allocated to us by our distributor, and we have not seen a disruption. So our strong belief is, as we resume volumes, that supply chain will continue to be there, and we'll be able to acquire the number of gowns and gloves that we need in order to do the 30, 40, 50 procedures that we do on a daily basis. So yes, we did outline that as that's based off of current volumes, but we have not seen to date an impact to the supply chain upstream. It is something that we will continue to monitor. We'll want to make sure that our burn rate and our replenish rate are on par. So essentially the amount that we're using on a daily basis, we can also refill. So it's something that we're going to monitor. It's also, I think, a key determinant on what the start date is. There's a question above that said, what is our plan, or what target date do we have to start increasing our surgeries? Again, this is in a way what Governor Ricketts wants to make sure that the hospitals and the health systems are monitoring in order to release us from this directed health measure on restrictions on elective surgeries. He wants to make sure that we have sufficient PPE to cover our daily business, as well as should an outbreak occur, that we can preserve and take care of patients in an appropriate and safe manner. So that's one question. I hope I answered that. Shifting gears pretty dramatically, we have a question here related to the bash. Are we still having the bash? We had scheduled to have the OrthoNebraska bash, just like we did last year at the slowdown in early June. Unfortunately, I don't think that it's going to be wise for us to do that in early June. That doesn't necessarily mean that we won't have one at all this year. I think, as we've illustrated with so many of the decisions that we're making, a lot of this is based off of the information that we have at the time and how that changes on a daily and weekly basis. Peg hit it right on the nose earlier. A lot of the resumption to normal depends on vaccine and treatments and testing. And while a lot of that is progressing, there's not a lot of clarity exactly what the capacity will be 2 months from now. We don't have a good sense of how this is going to spread 2 months from now. And so we need to make smart decisions in advance, but we also need more information to make decisions around long-term plans. So we're not going to hold the bash in June. I'm sorry. I had a great time last year. I think that really is a unique thing that OrthoNebraska gets to do. I don't think it's wise to hold that in June. So we'll monitor the certain circumstances. We'll monitor the plans that the governor puts in place around large gatherings. Same at the federal level with the resumption plans that President Trump outlined last night. We'll monitor all of those restrictions and guidelines, and we'll look for another time to get everybody together. So I think those are the big questions that came in. I don't think we have any more. I'm going to go ahead and bring the others in. Maybe any last comments from Dr. Reynolds? I'll add you, and then we'll close it up. So, Dr. Reynolds, anything to add as we close it up here today?
The only thing I'd advocate for is maybe we can have a virtual bash. That'd be the only thing I'd say.
A virtual bash. I think there is ways. I think there's ways to do a lot of fun things. Maybe just not in the traditional way. We have a good, smart team that thinks about these things all the time. Maybe there is a way to do something like that. Thanks, Dr. Reynolds, for joining today.
You bet. Thanks a lot.
Peg,
Yeah.
John, I'll bring you in. Any last? Oh, John's not there. Peg, any last comments?
Oh, I have some. Just a couple notes. I just want to thank everyone for the response we got for making masks out of the OR style wrap. I got so many, I couldn't keep track of them. So I want to thank, we got them from employees, we got them from physicians' families. We've got patients actually are volunteering to make masks. So we will be using those for the outpatient patients coming in. And as we get more of those and as we get them developed, and we're taking both cloth masks as well as the ones made from the OR wrap. And then the other thing I wanted to note is that with the N95s, we are, and because we're cross-training so many people and preparing for future issues, we are fit testing more and more people for the N95s, and we are, as normal, there's people who aren't fitting using the testing that we have available. So there is a more accurate test available through CHI in their occupational department. And so we'll be sending some of our employees who failed the fit test over there to see if they truly did fail or if they can wear them. So we're going to also, with the increased use of N95s, we're also going to be bringing the PAPRs out more for people to use. And for those of you in clinical positions, every year you get introduced and reminded again of the proper way to wear the PAPR. So don't be surprised if you start seeing more PAPRs out there as well. Thank you, everyone. It's been great group to work with. I'm so glad I'm part of Ortho.
Thanks, Peg. Great work. John, I'm going to bring you back in. Any last thoughts?
Yeah, just like everyone else, huge thank you to everybody for staying positive and bearing with us as we've moved through an ever-changing environment with different updates and trying to get things in place in short periods of time. So just wanted to say thank you for everyone for being patient and adapting to things quickly, and appreciate everybody's work over the last few weeks. It's been some long hours, and just appreciate everybody's team effort to really push to get everything done and keep everybody safe.
Great work, John. Thank you so much. So before I sign off, there were a couple questions that came in at the very end. Caitlin's asking, I just want to make sure that we're clear on this. Caitlin's asking, can we potentially start increasing surgeries next week as long as we have enough PPE for everyone? For clarity, what's going to happen is, based off of the guidelines that the federal government set last night, President Trump's kind of guidelines for getting back to a new normal, that's going to be interpreted by the governor at the state level. He is then going to probably set a number of rules on what infection rates look like, the decline of infection rates, the decline of cases, occupancy within for beds and for ventilators within respective communities, and then he will set those guidelines that we will need to follow at the local level. And so I don't necessarily know when that will be, but I will say that we continue to stay very connected with the medical community through the Omaha Metro Healthcare Coalition to understand how this all impacts Douglas County. Our Chief Medical Officer, Nick Brueggemann, as well as Dr. Burt, they're involved in those conversations. Obviously, that will influence, I think, some of how the governor thinks about resumption of elective cases. So I can't say exactly when we will. What I'm saying is there are clearly some key triggers that we will need to analyze. One of them is PPE. One of them is how much capacity we have to take care of patients as a community, as well as the directives that come from the governor. Those are the key things that we will be monitoring before we resume. In the meantime, John and the team will be making sure that our internal processes keep all of you and all of our patients as safe as possible. So I just want to make sure that we're very clear. There's going to be directions that are going to come to us, and in the meantime, we're going to make sure that we are very safe. So there was one more question that I wanted to tackle, and it was related to construction going on in our 4 ORs that we're adjoining to the existing hospital building. Our strong belief is that we need to continue on. We have and expect that the construction folks, the team members that are actually doing the construction, that they're following the exact same expectations around screening to get onto campus, around wearing face masks around individuals. All of those exact same rules apply to them. And additionally, we know that on the other side of this, maybe not May or June, but we have a long-term plan for those ORs. Stopping that now is not a wise choice. It makes sense to continue on to make sure that we're ready as we continue to grow. And so we've made the decision, with a lot of consultation, with the exact same rules for all of our staff members, to make sure that we are very safe with those construction team members that are on campus, as well as the financial considerations of stopping versus restarting construction. All of that was weighed in to continue on with that project. We think it's really important in the near term and the long term. So we are continuing on, and we think that's important. So with that, I think that's going to be the end of the questions today. Keep them coming. You can always email questions in advance. We'll make sure that we're prepared. We can add more slides and more data to the questions. So please get those in advance. But again, don't hesitate to add your questions as we go along here during these meetings. I want to end with, again, a huge thank you. Thank you for being patient. Again, thank you for being flexible. Again, it's going to be part of who we need to be in the future, being flexible, being adaptable. We've demonstrated that. We need to continue to do that. And then again, Please take care of one another, your teammates that are struggling with whatever may be they may be struggling with on that day. Take care of them. Everybody has their own challenges. We're all in this together, so take care of one another. And again, thank you. Until next week, take care.